Greetings from Dr. Bill Wyatt with the American Orthodontic Society, and I want to talk with you a little bit about the different problems that you might have in orthodontics. And one of them that I had every once in a while was a root resorption case that was sent to you to finish doing the work, and you had no idea, neither did the patient, is what caused the root resorption, but there it was, and somebody got it off of their back and sent it to you to try to finish that case. So I don't mean to say this bragging, but I've never lost a tooth from root resorption in all the years of doing this, and I'd hate to say this when I was practicing. I'd probably have the next case would I lose the tooth. But anyway, we do not really understand why it starts and why it stops, and there's a lot of things about it we don't know. So we just deal with it with kid gloves and treat it very easy. We don't put any stress if we can help, and just move the teeth as slow as we can into position. So here's what we did with this particular case, and I'm just going to show it through till we get the thing lined up here, and I hope you get something from it. I honestly don't know exactly what to tell you about root resorption, but we just took them. I have seen it that started from absolutely nothing that we could put our finger on, and a person that wasn't aggressive or banging their teeth around or anything like that would have half the roots gone on some of the upper teeth or something of that nature. We've got several of them in there, videos in there. So let's look at this young lady. This x-ray came to me, and if you look at it carefully, you'll see the upper centrals have the roots daubed off. And I tell you, do not ever take a case without doing records on them when you get them. I don't care if they had the records done the day before. You do your own x-ray and see if you can figure out what actually caused this root resorption. But you can see these two upper centrals look like the roots, they're over half gone. Now look at the laterals. They have nice long roots that go way on up in here, and the centrals kind of dub off like that. Now, I would handle this case very, very cautiously and take a lot of x-rays and explain and show the patients these teeth that have short roots, even the bicuspids, they're not too good. And this may be something that runs in the family. I don't know. But you don't know, and you got to get this monkey off your back. So explain it to both the parents that you do not know why this happened, and you're going to treat it very gently as you do this, and we'll take frequently x-rays, and if it starts acting up, then we'll slow down from that, or even maybe stop the treatment. I don't know. I've never stopped, but just kept going with them, and they went to a certain point, and then they didn't resorb anymore. So we went ahead and finished the case. Now, if that makes you feel any better about root resorption, I hope it does, but I don't have the answer to it. So let's look at some other pictures here. This is after we took the case and we put brackets on these teeth, and we're going to have to move it. It was a class 2 case, so we'll have to have class 2. So you've got hooks up there on both sides, and we'll be using class 2 elastics. We've also put an intruding arch on here, and we're depressing the lower anterior teeth with this arch wire there's a double arch wire doing that. And let's see how it goes. This was 8/25 of 2011 that we did this. And let's see, now on the next Panorex, I think this is 8/25. This is not a Panorex, it's a self, and this is taken on January the 31st of 2012. And you can see the resorption even in the cephalometric x-ray here across those two centrals up there. Now, don't, I would just as soon the patient transferred and went somewhere else. But sometimes I think the guy that sent them to you is just scared of it and he wants to get rid of it. But a lot of times they transfer from some distance away. Okay, this doesn't show too much here that we need to know. Now we go into another Panorex. Now these are pictures probably of the paper printout of the Panorex you get with these modern films. And you can see it looks like it 2/3 of the roots of these centrals are gone, and yet the laterals have nice pointed roots. Now down on the bottom looks like we get a little dubbing of the roots, but not a great deal. The upper second bicuspids seem to be short too. Now the case is in a class 1 relation. In other words, we've pulled this up and we brought this back some, but not much, and we have this lower 6-year molar is out in front like that, and that's what the 6 keys of occlusion, if you know about that, if you've done anything in orthodontics, you do. Now let's see, we go to the following picture, and this one is 3/14 of 2012, and this is 7/26 of 2012, and we virtually finished the case, and the roots of the teeth that are left there are still about the same as they were when we started. So we cleaned it up and want them to take real good care of this and use dental floss and always a little brush going between those teeth if you can clean them up. Now, I like to take a case like this, and when I finish, or else when I have them nice and straight, come on the lingual side and bond a wire to those teeth and go from cuspid to cuspid with that, and put a little extra bonding material on here and let them close up against that and leave a track. See, these brackets will be off there on the other side of the tooth, and you can put this on while these are being held in place with the brackets, and then bond each of these teeth really good with a good composite. And you have this on the lingual side, so you can pop a dental floss strand through the anterior part of this and almost get completely between the teeth. But I really bond these on good, and I just bond all 6 of those teeth together. And if you get I put a heavy, a fairly heavy lingual arch up here and bond it to those teeth so that this tooth doesn't, and the other one here, doesn't take any tearing pressure. It shares that pressure with the cuspids and laterals, and both of them are good. So that's what you might do, and you can tell this to the patients when you start, that if it doesn't resorb anymore, then I'll try to do that, and you can go ahead and do that. Now, if I've had teeth that just barely got the roots into the tissue, but if you really bonded that tooth together with the other teeth, where it didn't move back and forth, then this if you let this tooth shake back and forth every time they eat, then it'll never heal up there. It'll just continue to be there. So that helps to make it very rigid, even if you had to have a cast deal built for those teeth to go in here. But watch out it don't put anything at your bottom teeth, hit and pushes your jaw back. That might create a joint problem and shove these condyles back in this area here too much, and you'd have trouble that way. So have it where the lower teeth just come up and touch this thing or just set on it, but don't go against it, get pushed backwards. We've got a case with that made out of gold on, I think it's on this man called grinding the teeth. And he did this during high school, just had them ground off to nothing. We built teeth and just made a shelf for him to come in there with the dental replacement in there. So these are just some ideas or things that you can do. And we've had a bicusters extracted on this case, but I didn't do it. It came to me with this resorption like that. And so you almost have to take the case, and I don't recommend, I never have sent them away. We just always worked on them the best we could. Okay, here is the last, and I don't know, that's kind of in between here something. The wisdom teeth are out and the bicusters are out. And here we've got the bonded 3 to 3, and we bonded something on the lower and the upper. And that you would give some support to these two centrals and use a fairly heavy stainless steel wire, of course, to do that. So let's see, I think that this is where we started with this in 2012. Now here are the teeth. We finished them out. Those centrals are just as alive as they can be. The nerve and the blood vessels are not interfered with frequently in cases where you've got the root resorbed away and the blood vessel and the artery, like the artery in your vein and your lymph canal and the nerve and everything will be just as alive as can be, even though the root of the tooth might be off somewhere up here. It looked like that's about the way that was. It's about looked like a third of the root was left, and those teeth are tending to stay there. And if that young lady takes care of them good and everything, I believe these teeth will be with her for many years. She's not going to wear them out. Just don't try to bite anything really hard or try to tear anything with biting with your teeth like that. She could get some plaque scaled off some of those lower teeth. But that's the way it looks. And there's the upper bonded material, and it left a kind of a little shelf where the lower teeth kind of rest on that shelf that keeps the bite from deepening, and that supports this tooth. One of them is worse, I think it's this one. And you can do that, and that's what I try to promise the person. I have no idea if it'll get worse than it's losing, but if the person did not knock those teeth out and stick them back in, they shouldn't lose them. So we just go ahead and work on them like that. So let me see, this is the lower with a bonded 3 to 3, 2 that supports those teeth. Now this is that upper bonded that I want you to do. You put this wire, you close their teeth, and you see that your lower teeth come to about here on these, and now you come in and etch all of this, and you put this wire in place and hold it with a couple of threads or something, and then bond this with an excellent composite and get it fully bonded in here, and you can, if the person will not bite hard, you can let them just barely touch, and you look under there with a mirror and see if they're staying away from the actual wire, and you just make a pattern into this developing or hardening composite without messing it up, and that leaves you a pretty good shelf in there. So that's my answer to bonded anterior teeth. It's kind of shaky, and the person has to share that. It's not your fault, and so you unload it and let them know about it, so it's not you. If there's something comes in, they break something loose up here on these teeth and have to have it redone, you get them back in, you have to charge them for it. It's not something you guarantee. So anyway, I'm going to see what we have from there. Now this is a bite plate that we built to maintain the width and everything over here, and it kind of puts a supplemental amount of very thin acrylic over the bonded. You can see the bonded acrylic on the tooth here, and this is just laying right over the back of it. So if they eat with a retainer, it helps take the load where they might bite on that. And we recommend wearing that retainer for years after they get through with the case. And on the bottom, to keep that from going anywhere, we put a lower wraparound retainer. Nothing now across the occlusion. You don't need it and don't use it. And it'll snap over those teeth and lock in there, and you have to, if you have a problem with them coming out, then you put a slight amount of composite over the wire somewhere. You have a Vaseline on that, so they have to snap one side out and take that and then get the other side out. That holds it that way. So this is a wraparound lower retainer and holds those teeth in place. But all these retainers let the teeth erupt into each other, and they wear in just like valves on a car wear in like that. So, well, I hope you get something out of this, and you can. If you nothing else, the retention of these roots, or these teeth with almost no root on them. I guess you could take a tooth that just barely in the tissue. It should be loose and bond it rigidly enough, and it would keep the nerve and the blood vessel of the artery and the vein and the lymph and all this stuff in the clear, and the teeth would last. I've seen them last for years and years, and just put in there so it holds them in place. All right, let's see. Here is the young lady. She's a very nice, sweet young lady with a nice vertical height of the face. Everything looks good. She's got a good smile, and we're going to try to keep that tooth up there for the rest of her life. If she loses that thing, she'll be in your office the next day, and you'll have to put one on a retainer for her. But we have done that, but it didn't come from a root resorption tooth. I've never, really, honest to God, never lost one. That's unusual. I expect you could lose them, but I haven't. So hope you get something out of this. We enjoyed talking with you, though I miss having a class out there in front and being able to answer questions and talk to them and show them about that. But that's impossible now, and this video is a godsend. I just wanted to pass this out where anybody, anywhere else in the world, and we've got something on most everything you think about in orthodontics. And so I hope that you'll join our group and subscribe to it. So we'll say good night and hope this lady, I don't know where she is, or I've hidden her name here. Maybe she may see her face out here all over the world someday. So I hope she doesn't mind, but help people learn about it. So we'll pass this on and say good night to you.